cancer. But the task given to me is to talk about the feasibility of SBRT, especially in the Indian setting for high risk and node positive prostate cancers. We know for a fact that having a highly conformal radiation is definitely needed for delivering high dose radiotherapy to the prostate, and it has been shown to significantly reduce the amount of radiation dose that is delivered to the bladder and the rectum, and consequently reducing the amount of significant acute and late toxicities to the bladder and the rectum. But what about the availability of such technologies in India? So I looked at the ILORA portal, which maintains all the radiation facilities in India, and it shows that more than 680 linear accelerators are available in India across the country. And we did a survey of about 88 cancer centers which practice radiotherapy for prostate about 5 years back, and about 88 centers across the country responded to this survey. And it was shown that more than 95% of the centers have the capability of delivering IMRT, and in fact, 93% of the centers who responded to the survey were in fact using IMRT as their standard technique for treating prostate cancers. What about image guidance, which which allows us to precisely target prostates? And it's been shown that IGRT definitely reduces the incidence of acute and late toxicities when we deliver high-dose radiotherapy to the prostate, and also possibly impacts the biochemical control as well. Usually this is used on a daily basis when we deliver radiotherapy, but what about doing it on a less frequent basis? Our center and also TMH Mumbai have looked at the possibility of doing less frequent imaging to deliver radiotherapy. And it's been shown that the random filling of rectum and bladder definitely makes it difficult for you to deliver precise radiotherapy if you do imaging less frequently, and you would end up requiring a larger margin for you to cover the prostate adequately every time. But what about the availability of image guidance in India? Lack of image guidance in that survey, again, was reported only by 5% of the respondents from the 88 respondents. And most of these centers were using CBCT as their preferred image guidance, with only 17% using 2D orthogonal imaging for image guidance. And majority of the centers were also using daily image guidance as part of their protocol. So definitely the technology and the expertise for delivering SBRT is available in India, because I spoke about IMRT, and it's the same principles that applies for SBRT as well. What about the biology of prostate cancers in India? Before we go on to that, incidental diagnosis of prostate cancers after patient has undergone TURP for urinary tract symptoms is definitely something that we come across routinely in India. And in the POPRT trial, it was seen that nearly 1/4 of the patients did have undergone TURP when they were presenting for curative radiotherapy. And in this setting, it's usually a concern for late GU toxicities when you are delivering high-dose hypofractionated radiotherapy. And this particular setting has been examined in a matched pair analysis, where they have looked at non-TURP and TURP patients in the TMH in a retrospective study. And they've seen that it's relatively safe to deliver SBRT even in the post-TURP setting as well, with the most important consideration being the delivery of radiotherapy much later after the TURP has been done. In the West, most of the prostate cancers are diagnosed with screening, PSA screening, meaning that most of the studies for SBRT which have been done in the West have included low-risk and intermediate-risk prostate cancers, with very few representation of high-risk prostate cancers. But the prostate cancer in India is mostly symptom-detected, diagnosed, and most of the patients who are diagnosed with non-metastatic prostate cancers have high-risk prostate cancers. So we needed to generate our own data. So the first prospective study in India was conducted at Tata Medical Center. It included majority high-risk patients, and this earlier publication at a shorter follow-up showed good biochemical control with acceptable toxicities, and very slight worsening of the patient-related QOLs at the end of treatment, with improvement and settling down at a lower level with longer follow-up. This unpublished data of a little more longer follow-up of nearly 5 years shows that just for the high-risk group of patients in that study shows good 5-year biochemical and metastasis-free survival. Similarly, there's another retrospective data, again, just the high-risk group of patients from Tata Mumbai. Again, a very short follow-up. I'm not sure if this has been updated now. Good biochemical control and acceptable late toxicities. With that, the stage was set for a randomized trial, and the PRIME trial, which is very close to completing accrual now, was looking at the safety of SBRT in high-risk patients and node-positive prostate cancer patients. Recently, the interim results looking at the 90-day toxicities and QOL has been presented at the ESTRO. Nothing much in terms of the early toxicities between the two arms, very similar outcomes, and also the patient-related QOLs also pretty much similar between the two arms. While we wait for the longer-term follow-up and the establishment of safety of SBRT in prostate cancers, it certainly seems that it is feasible, even in the Indian setting, and it is already being used in routine clinical care with nearly 15% of the centers in that survey saying that they use it as part of their schedule for radical treatment for prostate cancers. And some centers said that even more than half of their patients are being treated with SBRT. Thank you.
We have 2 minutes for discussion. Thank you so much for finishing in time, sir.
Sorry, are we hypofractionating mainly for the convenience of the patient and clinician, or is it more efficacious?
It's more with relation to the convenience for the patient, sir.
Okay. And as Vedang was saying, probably maximum we can come down to is 2 sessions.
2 sessions, yeah.
And is similar thing being done for TMT for bladder tumors, or we are not doing on that front?
Bladder tumors, we have come down to 20 fractions, but I don't think we will go any further below that.
Thank you.
There is a confusing this thing about whether we have to give a radiation to the lymph node. When you are doing SBRT, how you manage the lymph node?
So these are all high-risk patients based on the results of the PAR-T. Even the PRIME trial, initially it was just the prostate alone. Now we have amended the protocol, and it is the elective nodal radiation is also given.
So along with that, you add something like a...
So the prostate gets about 36.25, and the elective lymph nodes get 25 gray in the same fractionation.
Thank you, Dr. Moses. I don't think we have any more questions. Now, to talk on guiding principles and challenges in the management of retroperitoneal and prostate sarcomas, I call upon Dr. Puneet Ahluwalia, who is the Director and Head, Uro-Oncology and Robotic Surgery at Medanta, the Medicity, Gurgaon. Sir, you have 8 + 2 minutes.
Thank you so much. Good morning, everyone, and thank you for having me here. So, every now and then we, as a uro-oncosurgeon or urologist, we come across a patient who has a large retroperitoneal mass, frequently involving more than one organs. Sometimes it is difficult to even make a diagnosis of the organ of origin. And so my talk is on that, only guiding principles and challenges in the management of retroperitoneal and prostate sarcomas, and I'll be talking about the surgical aspect of it. So these are the large tumors of the body which are in the retroperitoneum and frequently involve more than one organ, which makes the surgery all the more challenging because you might have to remove multiple structures, even the vital structures, major vessels. And it is not uncommon to have very large masses without any symptoms. The symptoms at best may be vague, dull-looking pain, or the patient may be entirely asymptomatic. CCT is usually done because of a primary investigation. CCT is done, and mostly it tells us about the local extent of the mass, and sometimes MRI is required, especially in cases where larger vessels or IVC involvement is there. So whenever we are dealing with it, first up, it is very, very important to have an idea about what histology you are dealing, because it is not only important in terms of making decisions, it will also decide the oncological outcomes. So the two types are mainly liposarcomas and leiomyosarcomas. So these are not very common tumors. These are rare tumors. Suppose kidney tumors, if we talk about, so less than 1% of the malignant kidney tumors are sarcomas. So the literature also is not huge, and not many randomized trials are there on these sarcomas. But there are few specialist working groups which have, evaluated the treatment effects of treating these sarcomas. So the histological subtype is important in treatment decision making, and so needle biopsy is done. It rules out benign tumors such as angiomyolipoma, which sometimes mimic sarcomas, and confirm the diagnosis. And it also, is important in evaluating the tumor grade and deciding whether neoadjuvant therapy is required or not. Now, there are some randomized trials like STRASS trials, which are evaluating the role of radiotherapy as well as chemotherapy. STRASS 1 evaluated the role of radiotherapy, and in some histological subtypes, especially like liposarcomas, it may be important. But STRASS 2 is still going on with evaluating the role of chemotherapy. Staging investigation, at least a chest CT should be done. Lung is a frequent site of metastasis, and whole body PET CT usually is done nowadays, but it is still not the standard. The important thing to note is that if you are dealing with a sarcoma, there will not be any lymph node spread. Sarcomas do not spread to lymph nodes. So surgical approach, surgery is the mainstay of the treatment. So you have to plan your surgical approach very carefully. You have to, know about the caveats of the surgery, the implications of your surgical treatment on the overall outcomes, and it is not just the cutting out of tumor. So you may plan your incision depending upon the location of the tumor. It may be a midline laparotomy with lateral extensions or a thoracoabdominal incision. It depends upon the location of the tumor, and also you should have a wide exposure of the major vessels surrounding it. Goal of the surgery is very, very clear. You should have an en bloc resection of the involved adjacent organs. Try to attain negative surgical margins. Lymph node dissection is completely unnecessary in these tumors. In fact, you may be doing harm to the patients if you're doing lymph node dissection in these patients, because it may lead to increased morbidity with chylous leak. Extent of resection, the importance of extent of resection will be discussed in further slides as well. So obviously you have to resect all the involved organs. One or more organs are resected in 58 to 87% of the patients of retroperitoneal sarcomas. And most commonly it is ipsilateral nephrectomy or partial colectomy. And resection of major vessels is done in 10 to 15%, which is a big number. So now there's something called compartmental approach when you're operating on patients with sarcomas. So it is mainly followed by Italian and French sarcoma groups, not so much by the US group. The fundamental concept is that even without obvious involvement, adjacent organs or structures should be resected and the surfaces should be cleared in order to achieve the maximum clearance. This is analogous to obtaining a negative margin in soft tissue sarcomas of the extremities. Basically, this is an extrapolation of that concept. And this is a study which evaluated the effect of compartmental resection on abdominal recurrence rates. You see, if you do just a simple complete resection, that is not enough. If you do a organ resection along with the involved organ, that does better, but compartmental resection does even better. So this is not something which is indicated for all the patients. It again depends upon the histologic type. So if once you have the histologic type, it anticipates the origin and the local extent of tumor. For leiomyosarcomas, these tumors are not locally aggressive. These, when they occur, they are usually distant recurrences, so compartment surgery may not be needed. Similarly, liposarcomas, they are usually multifocal, and there may be presence of synchronous tumors, and usually in these tumors, you need to clear adjacent fat, or compartmental resection may be advocated in these patients. Histological subtype also tells you about whether it is well differentiated or a dedifferentiated tumor, and it will prognosticate a patient in terms of oncological outcomes. Now, the importance of histological margins in these surgeries is very important. So there has been study which evaluated the histological margin in terms of overall survival. The piecemeal resection or R2 resection is totally to be avoided. It is as good as not doing any surgery. In fact, it may be doing a harm to the patient because you are giving a morbidity, and the overall survival results are as good as only doing a needle biopsy or no surgery. The best results are with complete resection with negative margins and a compartmental resection in some histological types. But even if you have R1 resection with microscopic positive margin, that is also still manageable. So this was a study by a French sarcoma group which evaluated the local recurrence, distant metastasis, and overall survival depending on the prognostic factors. And it was seen that for local recurrences, no adjacent organ involvement, specialized surgeon, and en bloc resection were important prognostic factors. And perioperative RT added in terms of improving local recurrence rates. Now, when we talk about specialized surgeons, it means specialized surgeons who are treating or operating on sarcomas. And the minimum number is, there are very few studies. The minimum number what they've written is around 10 to 12 cases per year. So that means one case a month at least you should be doing, especially for sarcomas. For abdominal sarcomatosis, again, these first three prognostic factors are the same, but histological subtype is an important thing. The well-differentiated sarcomas are better in terms of abdominal sarcomatosis. And overall survival, the grade is very important. Grade 1 is better rather than grade 3. Similarly, this is a study by John Hopkins, and they echoed the results from the French sarcoma group. Leiomyosarcoma had a highest rate of distal recurrence. Perioperative RT reduced local recurrence. Distal recurrence was grade dependent, and overall survival was better in patients with complete resection. So oncological outcome, local recurrence occurs in 49%, reduces to 27% with compartmental resection. Distant metastasis in 12%, and overall survival is still only 39%.